Welcome to this webinar on the mini-focusation on interventional cardiology and coronary abnormalities. My name is Julia Grapsa. I'm the editor-in-chief for JACC case reports, and I would like to welcome Dr. Joel Giblett, consultant cardiologist for Royal Papworth Hospital in Cambridge in the United Kingdom, and Dr. Eric. Hi, Joel. Thank you for being here. And Dr. Eric Bates, who is our deputy editor and also professor of cardiology at the University of Michigan. Hi, Eric.
Hello, Julia.
So thank you both for being here. I forgot to mention that also Joel is our editorial consultant for the journal. And I will start with the first case that has the title Takayasu Arteritis with extensive cardiovascular, neurovascular, and mesenteric involvement. So the first author is Dr. Adam Caster, the last author, Dr. Henry Honda, from the University of Cardiology in Los Angeles Medical Center in California. So Eric, what do you think of this case?
Well, Takayasu's arteritis is a very popular diagnosis to be tested on competency examinations. I'm not sure in 40 years I've ever made the primary diagnosis, though I've seen a few people with it. That probably comes through the rheumatology clinic, and now with CT imaging, the diagnosis is more easily made. I received several of these reports because it's a perfect subject for a case report. And this one was very nice because it is well written with an excellent discussion reviewing the arteritis syndrome. And it was diffuse. It had involvement of cerebrovascular vessels, the aorta, renal arteries, mesenteric arteries, iliac arteries, and even the coronary arteries, which is a relatively less common artery that's involved, because usually this is a fibrotic inflammatory disease of larger arteries, sometimes medium-sized arteries.
Perfect, that's great, thank you. Joel, any comments?
Well, I mean, I think that I think that Eric said it was very widespread, and it was a sad case reading through it that it was picked up late at a stage where the disease was really overwhelming for the patient. I think the authors made very reasonable comments, and they discussed the possibility of bypass grafting as a treatment, but clearly they decided that it wasn't appropriate. I think the involvement of a multidisciplinary team with lots of specialties is key to managing these patients because they're affecting so many systems.
That's great, thank you.
Arteritis is an interesting diagnosis. We're talking a little bit this last week about Kawasaki disease in pediatric patients with inflammatory arteritis. Giant cell arteritis is a disease of patients over the age of 60. This most commonly is a disease of patients under the age of 40 and much more common in women. This patient was a man. And as was said, he had diffuse severe disease and complications and really had no chance for a good long-term outcome. So it is a terrible outcome and an impressive disease as represented in this case report.
Thank you very much, both. I will move to the next case, which has the title Supporting High-Risk Percutaneous Coronary Interventions with Mechanical Devices. And the first author is Dr. Stephen Wilkinson, the last author, Dr. Hannah Park from Spectrum Health in Michigan. Joel, I would like to start from you first.
Yeah, go for it. So, I mean, this was a case of a 62-year-old gentleman who was really in the last chance saloon, so to speak. He'd had a previous MI, a bypass graft 22 years ago, and actually only had a single graft remaining supporting his entire circulation. He had poor left ventricle and was having non-sustained VT and presented really in a very difficult situation. I think they decided that they wanted to treat the graft that had high-grade stenosis, and they discussed ways to facilitate that. And the heart team discussion that they came to the that they needed something such as VA ECMO to support the circulation under the circumstances that the patient found themselves in. And as we can see, the case report shows that there was successful PCI. Actually, the patient was on the intensive care unit for a very relatively short period of time. They were able to decannulate the patient in the lab, so things went very well from the point of view of the patient, and he actually had a very good result. I think I was impressed by how well they'd handled the heart team discussions and the options that they'd explored with the patient. I guess they're entering what's very much a data-free zone in terms of knowing what the benefit of this is. You know, there are very few patients that are getting PCI in such extreme circumstances, or where they're often getting impeller, or in Europe still getting these cases done with an intra-aortic balloon pump. So, you know, there's a question that we need more data to really understand the benefit, but in this case it was a nice case report. It demonstrated very clearly that this is some patients.
Thank you. Eric, any comments?
Yeah, the other consideration is on the vein grafts is whether distal protection devices are needed. This is a 20-year-old graft, I guess. So focal stenosis, no reflow would be devastating. So that would make a stronger case for having a support device placed prophylactically. There is controversy on which support device to use in the US. There's a concern that they're being overused because the device is so easy to place. But when you need it and it bails you out, it's a great relief compared to the old days where we didn't have these types of support devices and patients occasionally had death on the cath lab table.
Perfect. Thank you so much. Now, Eric, I will move to the next case, which has the title Embolic Stroke Caused by Aortic Raptured Plaque and Thrombus Visualized by Angioscopy. The first author is Dr. Yoshiharu Higuchi, and the last author, Kazuhisa Hodama, from Osaka in Japan. Very interesting case here.
Yes. We've spent time recently talking about intravascular ultrasound and about OCT, but there's another intravascular imaging technique called angioscopy that the Japanese investigators have been using for at least 20 years that gives you direct vision of the atherosclerotic plaque or the vascular wall if you can get the blood interface out of the way. And we thought this was interesting because, number one, it reminds us that there is a test called angioscopy available, and number two, with this great interest in stroke in recent years, particularly due to atrial fibrillation, this highlights again the possibility that cryptogenic stroke may not be cryptogenic if you can't find it on neck and cerebral imaging or cardiac imaging. Aortic grafts and even atherosclerotic aortic wall can ulcerate and cause thrombus, which can embolize to the head. So this is a very nice images, as you can see. The interesting thing to me is they ended up treating the patient with long-term anticoagulation therapy, and I'd be interested whether you two would have preferred antiplatelet therapy for an atherosclerotic plaque rupture and thrombus formation, or whether anticoagulation therapy is the proper therapy for a thrombus originating from the aortic surface.
Well, I guess go ahead, Julia.
Shall I do it? Joel, what did you do?
I guess that nobody definitively knows the answer to that question. I think that anticoagulation is a reasonable option in the case of a cryptogenic stroke. I think it was an interesting paper. It was interesting that the same group published a study in JACC on patients undergoing elective angiography just a couple of years ago, and they found that they could find these ruptured plaques in 80% of patients undergoing elective coronary angiography. So I guess, you know, whether the presence of these plaques in somebody is causally linked to their stroke is going to be a difficult question to answer at this stage. I think anticoagulation is reasonable, but I don't know the answer to that for sure.
Yeah, I used to do left ventriculograms when I was working in the lab. And if you do a good RAO left ventriculogram, you can actually see the descending aorta, and you can see calcification and sometimes ulceration on the aorta. We don't usually look at the aorta when we're doing left ventriculograms, but I guess the other question is if you think it's an aortic ulceration or graft material or even the aortic valve with atherosclerotic changes and the substrate for thrombus formation, is that still a cryptogenic stroke? Or is that a plaque rupture or thrombosis stroke? And I don't know the answer to that either, since I'm not a stroke expert. This case report made me think of anticoagulation versus antiplatelet therapy, and whether if you have aortic stenosis or you have a prosthetic ascending aortic graft, or if you have atherosclerosis in your aorta, whether that constitutes still a diagnosis of cryptogenic stroke, or whether you can call it an atherosclerotic source for the embolization.
Very interesting, thank you. I will move to the next case, our fourth one, which is coronary artery occlusion caused by intramural hematoma due to in-stent dissection. And here, the first author is Dr. Yasushi Ieki, and the last author, Dr. George Siontis from Bern University in Switzerland. Joel, your turn.
So yeah, so this is an interesting case report, and this is a case report that I guess should be very humbling to any interventional cardiologist operating. This is a 54-year-old man who came in and underwent a PCI to a high-grade lesion in his proximal LAD. It's interesting because, you know, in a sense, the authors did everything right here. They did an OCT-guided PCI. They had a good result broadly. They had their PCI showing that they'd got their stent up to 95%, very little residual stenosis, no significant edge dissections to see there. Angiographically, it looked very good. On the OCT, there was just a little bit of minor in-stent dissection, and I think you know, under most circumstances, most interventional cardiologists would have left that alone. They wouldn't have gone any further with any further post-dilatation. But in this case, as we can see on the next slides, the patient represented with an occlusion of their. Well, there we are. We can see the good result, and the patient represented with an occluded LAD, and in fact, this in-stent sort of minor area of dissection had propagated beyond the stent and caused the vessel to occlude with hematoma in the wall of the vessel, which the authors were able to rescue with further PCI. So I thought that was interesting because I thought really they didn't do anything wrong. It was a good result, and we need to always be humble that even the best results for us as interventional cardiologists can have unexpected consequences. Many operators would have done that PCI without the use of intracoronary being, wouldn't even have known that in-stent dissection existed after the first case. So that was really my thoughts. And whether you had any comments on the case, Eric?
Yeah, as you say, I've always stated that PCI is a humbling sport. Before stents, we used to try to achieve dissection of the stenosis, because that means that we'd ruptured the plaque and enlarged the lumen. The risk, of course, was dissection causing acute thrombotic occlusion, which was a problem before we figured out antiplatelet therapy and before stents were used, or restenosis because the cracks filled in with intimal hyperplasia. So no procedure is without risks, even though they're rare nowadays. And I agree, you just can't promise a perfect procedural outcome, even though angiographically it looks like you got a great outcome. So it's an interesting case. Just reminds you that no procedure is perfect.
Perfect. So thank you so much, both of you. And now this is the last case of this webinar that has the title Orbital Atherectomy through Left Main Stent Strats, complicated by catheter entrapment and stent avulsion. So the first author is Yutaka Matsuhiro, and the last author, Dr. Yun Tanuchi from Osaka, again in Japan. Eric?
Yeah, talk about a humbling sport. This patient had previously a single stent implanted from the distal left main into the left anterior descending artery, jailing the origin of the circumflex artery, and then came back and was found to have ostial and proximal circumflex artery disease. So this is basically the challenge we always have with bifurcation lesions. You can rescue acutely by going through the stent struts with a small balloon. Sometimes you can do the culotte stenting and put a stent through a stent. These operators decided that they wanted to predilate the lesion with the orbital atherectomy and prepare it for better stent implantation. And you can see in panel A, the important teaching point on this case is the right angle takeoff of the circumflex artery where the three arrows are from the left main artery. You can call that an obtuse angle if you look at it from one direction, or an acute angle, but it's at least a 90-degree angle, meaning that to go through the stent struts, your catheter has to take at least a 90-degree turn, if not 110 or 120 degrees. So they got the orbital atherectomy catheter through into the circumflex artery, and they turned it on and started to prepare the lesion. But then the atherectomy catheter got stuck when they were trying to withdraw it, and they tried some different techniques and were finally successful in withdrawing the catheter from the circumflex artery, but they ended up with the stent caught on the catheter, and they avulsed the stent from the proximal LAD and the left main artery, and were fortunate enough to have a stable patient and re-stent the left main LAD, and then ended up with a good result. But it is important because it should ask us in our pretest planning, with all these new devices we have, when it's safe to go through the stent strut to do imaging or balloon work or stenting or atherectomy. And I think the message is the more acute the angle is, the more likely you are to get in trouble. A shallow angle, you can move in and out, but the 90-degree bend on a catheter that has a bulb at the end with a little higher profile is problematic. So what I learned from this case is we shouldn't do orbital atherectomy through a stent strut if there's a fairly large angle between the main artery and the side branch. It's also been shown a couple of times with the cutting balloon catheter, another stiff catheter. We found some prior reports with the same complication described.
Interesting. Joel?
Well, I mean, I think I agree with everything that Eric said. I mean, I have to say, I wonder whether actually I would be taking an orbital atherectomy or rotational atherectomy or any of these devices through old stent struts. I think that seems like a very high risk strategy. It is actually a contraindication on the Diamondback to do that. So they were operating outside its working parameters, and I think they've done very well actually to rescue this. This could have been a catastrophe for this patient, so they need the credit for rescuing the situation. In Europe, I wonder whether we would have the advantage here of being able to use shockwave on the coronary arteries and the calcified situation there, which is going to be actually a much safer technique to deal with calcium in this situation. But I guess that's not available everywhere. And I think that would have been one thing I would have done. I think I probably would have, if I was undertaking this case, I would have been trying to deal with this with balloon treatment first. But it's a humbling experience when you on the end of these complications, and they've done very well to get this patient to a good result at the end of the day.
Yeah, I think the balloon angioplasty is the easiest, quickest way to go at that. I'd be a little concerned about whether or not I could get a stent to go through the stent strut through that acute angle with the guide catheter prolapsing down and trying to make that acute angle. That can be, you can have an easy balloon angioplasty and have great difficulty trying to negotiate that angle with a stent. especially if they chose a longer stent. You might have to load this with a couple of short stents to complete that.
Yeah.
Perfect. Thank you so much. It's very interesting. I was thinking that I would like to be in the cath lab with both of you. I would definitely learn a lot. Thank you very much. So we reached the end of this podcast. I was wondering if you have any take-home messages for the audience, any comments from your experience. Let's start with Eric.
Yeah, Julia's developed an outstanding journal with, I think, more educational content per page you read. So I strongly suggest that you pay attention to this journal. And if you have good cases, please send them to us. We're looking for great content. And you can see on these cases we saw today that we're receiving it and we're sharing it. So congratulations to Julia for launching such a great journal.
Yeah, and I think I'd agree. I think, you know, in preparing for this this webinar today, I took these cases and showed them to a couple of my colleagues, and it stimulated really good, really interesting discussions. And actually, that's a place that this journal can be used. Is, you know, you can take these cases and talk about them with colleagues, and use that to sort of learn together, rather than just sort of. Often when you're reading papers, you're often sitting there by yourself, but actually these cases are a great jumping off point to good conversations with colleagues and shared learning.
Thank you so much, both of you. Thank you for being available today to do this webinar. And a big thank you to the audience for listening to this podcast webinar. Thank you.